Okay, good morning, everyone. We were trying to give it just a few more minutes to make sure people would wrap around. But my name is Jonathan Parr. I'm a physical therapist, and Shelby Foti, also a physical therapist. So we're going to talk today about alternative rehab methods for traumatic brain injuries. And then at any point, it's pretty open. I'll usually leave more time at the end for any questions. But if there's something specifically you don't want to forget during, just go ahead and raise your hand and we'll answer it as we go. So today we're really going to cover, your typical TBI impairments, but really our focus is really on benefits of introducing new stimulus and how PT can affect really progress by adding new stimulus versus maybe your traditional methods of physical therapy. We're going to go over typically what you find in clinics or at home versus some alternative methods, just adding a little bit more creativity and education on what you can do on your own as caregivers, parents, as well as how to differentiate where your child is going to need more specifically more therapy in certain areas and then versus other areas. And then a little bit about what we do. So start off with a little introduction about myself. I was a former American Ninja Warrior, and the reason I say this because I'm going to talk about new stimulus, and this is where I learned a lot about introducing things that excited the brain and how the body responds, whether it's a stress response or it's a calming response. And so the 6 years of experience on the show, in addition to the 13 years of experience that I have with traumatic brain injuries in both pediatrics and adults, really got my mind into, okay, how can we combine more of your strength and conditioning principles, your obstacle course training, along with traditional methods of physical therapy related to traumatic brain injuries. And then I'll let Shelby introduce herself.
So I'm Shelby. I am kind of a CrossFit athlete, not competitive, just recreationally. But that's really how I got into physical therapy, was by the CrossFit gym that I was in whenever I was in college. I had two really good, I guess just say mentors that I worked out with that were physical therapists. And I was like, you know what, it'd be so cool for someone to come to me saying, hey, this hurts, or this is what's going on whenever I perform X, Y, and Z. How do we fix that? So that's really how I got into therapy. And then kind of on the neuro side of that, or just as treating our patients that we have, it's really putting into anyone can do pretty much everything, right? That's a kind of a vague way to put it, but like, let's just say we have our patients that are doing pull-ups and dips. Well, that's exactly what I do training for CrossFit or coaching CrossFit. So kind of putting those two methods together rather than just sticking to one avenue that you have to go by this neuro rehab book or you have to go by this exercise book. So we kind of cross train those two.
And then this is just a little bit of background. I always show this so people have a better idea of having gone through this myself. This is my sister. She had a lesion in the brain. So this is where I started to get more deeper into brain injuries. So she was 21 at the time, but hers was very complex. So she went to a lot of physicians. A lot of people weren't sure what to do. And at that time, forms of therapy were not where they're at today. So initially, she did some therapy that, did well, but it wasn't until she found the person who's working with her here, who really helped her essentially get back into walking, and now she's doing fine. But looking at this and seeing, at this time I was 16, and so really looking at the things that they did that were non-traditional as a way to essentially stimulate the brain and keep her active and engaged in the actual task, I feel like was a big part of why she got better so quick. So that's where we're going next with how are we gonna, whether the child is, from 3 months old all the way to 18, 21 years old, we're gonna cover like a pretty broad area. So if you have questions depending on the age of your child, those are the questions that we'll wanna hear because we'll have to answer them specific to that. So Shelby, we'll go over some of the...
Yeah, so a lot of things that we work with, I guess the list is here, but for example, like a leg length discrepancy or, that's about the leg length discrepancy. How we deal with that is one way where we or one patient that we have, we had him bring a flip-flop essentially that we would put to the bottom of his shoe to, I guess, correct for that leg length discrepancy. And we would train that for just part of the session while walking, so he would get used to how it should feel, right? So where it would be more normal rather than kind of dipping down each time. So we do that, but then the other part of the therapy session would be not using that flip-flop or that shoe lift essentially, just so he would know, okay, this is how it's supposed to feel whenever it is corrected, and then this is how it feels without it being corrected. How do I put that together? Because he didn't have the shoe lift right away. So kind of being able to use with the assisted device or with the shoe lift, and then without it as well. So it's like a very I guess prime example for us for one of those. Another, or a couple of other things on here, difficulty walking. Patients that kind of are either learning to walk that don't exactly are not able to yet. We have devices that we use. This is one of them here. And then we kind of lead up to it. So whether it's just standing task, getting the correct hip, trunk strength, kind of even just body awareness or proprioception for that. So it's little pieces that we break down prior to getting them up into the actual walking device that we use during our session.
And I think just feeding off of what she was saying with leg length discrepancy, for those who don't know, it's when one leg is slightly longer than the other. So sometimes that could be due to an accident. Sometimes that could be from scoliosis, the way the body shifts. It actually changes the way the pelvis sits. And a lot of times, initially when kids are trying to learn how to walk, a lot of times that's not really checked. So if they're having difficulty standing, if they're having difficulty walking, a lot of times if they're not in alignment and lacking that awareness, it's much more challenging to figure out how it is that they're even going to get up on their feet and move. So it's very detailed from an assessment standpoint. When you're thinking about how you're constructing programs and how you're constructing like your plan of care of where you need to start, because that baseline, what she was saying about the awareness, is each person, let alone each child, needs some form of awareness, and without having that, it's hard to have that go past the fundamental of what you would need to even get certain movements going. And then as well, that goes with balance deficits, that goes with falls. I mean, even increasing spasticity. So we know that spasticity can occur more when the body has more stress or they're overworking. And so finding ways to minimize the amount of overworking that you have could just be as simple as regulating or aligning their feet in the right place. So we're going to dive more into that from a PT standpoint of what's traditionally tested, what's traditionally done versus alternative ways to handle these to better prepare your child for more success when it comes to rehab. And then we'll go over some of the traditional interventions that we see from a PT standpoint. So a lot of times it's either physical therapy that's brought to your home, maybe you're going to a clinic, a lot of times initially an inpatient. So there's certain things that you normally find, but we're going to teach you a little bit more about some other ways.
Yeah, so typically, let's just say things are from a traditional standpoint just kind of set in one area. So you're kind of either if it's just the typical room or even like in your home, like a typical space to be looking at, or you're just focusing on that one aspect, that one exercise that you're doing. How we try to approach therapy or rehab is by giving multiple stimuli or multiple things to work on. So rather than just working on balance alone, let's work on balance and let's work on a visual deficit. So a visual deficit meaning if a patient isn't able to follow a moving target smoothly, or if they have difficulty just maintaining a focus on an object, how can we put a balance exercise, or how can we incorporate a balance exercise with a visual tracking or visual training exercise? So it's more so of adding different stimuli and also changing the stimulus that the patient is treating in, or I guess doing their rehab in. That way, whenever they are out and about going into different stimulating places, you're able to adapt to that quicker or better rather than just only knowing the space that you're in. Do you guys have questions about that? So that's a big one, I guess, our main alternative way of how we approach, I guess, just rehab.
Yeah, and so even with traditional interventions, depending on the age of your child, it might be if they're just sitting, rather than actually focusing on more like combined components of the skill. We don't ever just sit. Like even if we're sitting, we're probably still scanning. So finding ways to introduce new stimulus, whether it's lighting, whether it's putting food next to them on the other side that they may not be fully aware of, depending on the type of injury they had. Brain injury depends on the type of visual deficit that they're having. Even if you're going to for an example, in an outpatient clinic, they may have, especially for younger kids, maybe swings, and there's a lot of different things. And those are your alternative methods versus just essentially laying them on the floor and then kind of like moving their arm, moving their legs. There has to be different stimulus that is also targeting the same thing. So what she was mentioning in the home, if you're just treating in one home, or excuse me, one room in your home, the child may only adapt those skills to that one room. And so you have to think about, okay, what is it like in the kitchen, backyard? Mm-hmm. Is there noise outside? Is there wind? Because a lot of these things may actually cause more tone or spasticity depending on what they feel. And so keeping that in mind when you're doing things is a big part of essentially beginning their progress towards recovery, and understanding those new that new stimulus also helps rewire the brain from a plastic standpoint, neuroplasticity. And so anytime that you give a child new stimulus, it's constantly remembering that and it's rewiring. So if I know a lot of times in outpatient therapy, from both neuro and non-neuro, there'll be like a plateau, so to speak. Like, okay, we've reached this point, we can't do more. And this is where we remove that plateau and constantly provide more information to the brain. And the last component, and we'll dive into this more as a whole, is vestibular activation. So if you're not familiar with the vestibular system, it's in your inner ear. It's essentially what gives you the awareness. It talks to your brain on where you're at in space. It has to do a lot even with visual movements too. If visual movements aren't coordinated enough, it's going to affect the way your vestibular system is working. So there's a lot that goes into that, especially after a brain injury, that you'll need to have as a way to build on other skills. And then we'll talk about this.
Yeah, so for strength training, we have a variety of different ways that we target either a specific body part. So it's listed here as upper, lower body, and then also the trunk. But then we have ways that we can incorporate the whole body. So for instance, where you're in quadruped, right? You have all four limbs with target to the ground. So you're getting weight bearing through all four limbs, but then let's add rowing to that. Or let's add, so we do it with cables a lot, or we call them jump stretch bands. It's basically just a resistance band. So we're being able to have a stimulus through all four body parts or all four limbs, and then we're also going to add movement. So you're getting a lower body, you're getting a trunk because you have to have the core control to maintain that, and then you're also getting an upper extremity, one, a single arm, and then two, an actual strength for the shoulder. So we like to target things kind of in a, either if we are doing the isolated limb, but also as mainly a whole body, because that's going to have a lot more carryover for a prognosis standpoint or just kind of a longevity standpoint as well, because we're able to give that awareness in all different settings. So let's say in sitting, we really focus on keeping whenever the patient is sitting down, trying to keep the lower extremity, the legs grounded. We can do that either from a tactile while holding the knees or even adding weight. So then that gives them the stimulus of actually having weight bearing through the legs even though they are sitting. So trying to, and then from there you can do, some core or some upper extremity things. So you're targeting the targeted limb, or you're exercising the isolated limb, but then you're also getting a whole body awareness through that one exercise. So it's a big way where we're a little different, where we're not just going to focus on just the one problematic area. We're really trying to get everything involved, no matter what exercise or no matter what we're doing.
Yeah, and even feeding off that with when she's referring to like putting weights on the legs and getting more information to the feet. There's a lot of times, and if you do this right now, if you're sitting and you lean forward, you can feel the amount of pressure that goes into your feet just by leaning forward. And so even doing like a slower approach, slower progressive approaches also helps with bigger skills, but you have to really focus in on the small skills. And so whether you're incorporating weight bearing with sitting, but also adding some sort of visual stimulus where you're either looking or maybe they're trying to reach, or let's just say they're completely dependent. They don't really have any active movement on their own aside from the spasticity that they have. Then you can find creative ways to get them in positions to where once you have them in certain positions, now you can still try to recreate some of that visual stimulus. Again, because we're trying to tap into the vestibular system, we're trying to give them awareness, we're really trying to target these deeper systems that have a bigger impact on the rest of the body. And when it comes to other traditional methods, whether they're using bands or weights or anything like that, really what's important is, depending on the age of your child, like if, from 3 months to, let's say, 3 years old, there's certain skills that they're going to have during that time versus someone who's 8 years old to 12 years old. So you can increase the degree of difficulty with it and also really, really bring it down. But various ways to do it is looking how many different things can I accomplish in one position, because not everyone has time, especially if you're doing therapy at home and you are the primary caregiver and maybe only going to therapy once a week. I use this little thing here is where this little jar of chocolate here is the amount of time that the parents spend, and these 2 little Mentos are what they get from a PT standpoint. So when you really think about what's going on here, it's really important to understand what you do at home. Like, you can be the therapist, and so finding different ways to do so that's safe for you, and then also that is a little bit more specific than what you might find from a traditional standpoint. And then this video link was not working, so we'll show this at the end. But this is kind of an example of someone who's learning certain skills or sitting stability by reaching forward, but also keeping it in a gym setting. And that's where a big part of what we do is changing that area. We use the gym a lot because it's a natural place for someone to get into, increasing that motivation, even whether they're a child or an adolescent. It's something that the environment goes, it takes you pretty far. So, but as far as balance training, so we have the strength training and now moving into balance training, which is kind of how we're starting to cinch it all together. Yeah,
so for our balance training, let's just start in sitting, right? So if we have someone in the sitting position, we can add the dyno decks underneath them to make that an uneven surface. So that way they're having to find where their pelvis is when they're sitting. So like you are on a soft surface or on a cushion surface here, but then you're also having to know what is your upper body doing as well. So of course, whenever we first get started, helping them, assisting them with the trunk, the upper body part, but letting them get a feel for, oh, my pelvis is moving forward and back or different ways. Kind of how I talked about the time before with you're in the sitting position, letting the lower extremities, letting the legs be grounded, kind of teaching them, oh, your legs are actually helping you move the pelvis forward and back. So breaking down something as simple as just sitting on either an even surface or an uneven surface. We kind of move through that for our, let's just say, standing exercises or standing things we do, rather than just statically standing on something or on an uneven surface. We like to target balance by, or I guess walking or standing balance. We use resistance bands. So we kind of pull them in different ways, and you're having to almost fight like you're having a, what's the word that you push? Yes, a perturbation to them. An external touch. So it's kind of shifting them in another way. Let's say it's the band pulling them another way, and they have to fight it. Whether they're doing that on a somewhat even surface, we have mats at our gym, kind of like gymnastic mats, but we also have a BOSU, so they're standing on that BOSU, that uneven surface, while we're pulling or moving them in different ways. So it correlates to if you're walking on an uneven surface, if you're sitting on a hard surface or a soft surface, trying to bring balance into multiple different areas, again, rather than just one specific area.
Yeah, and I think too, again, a lot of this is depending on the age of the child, but a 3-year-old is probably not going to be in a BOSU, whereas like maybe like a 14, 15-year-old would be. And BOSU, for those who don't know, it's that the blue ball at the gym with like a black flat thing that kind of tips all over the place.
It's an exercise ball cut in half.
Yeah, basically. But the idea behind this too, again, what we're thinking about awareness is that with balance, there's so many systems that are involved between what your inner ear, the vestibular system, is actually picking up, what you feel in your body, typically what you feel in your feet, and really what your brain is processing. So if you're trying to initiate balance, you have to take into consideration these three components that are actually happening. So, for it to transfer over into other skills, for an example, if in feeding, like if a child is just going to be sitting and feeding, you want them to be able to hold their balance while you feed them. What are ways that you can do that? And again, also changing the rooms that you're feeding in. Whether you're using a pillow, maybe it's like a soft blanket. Now, we have to consider that not every kid can just sit on their own, but there's various ways of support that you can gradually release as a way for them to progressively get better versus having them supported and completely without it. Doesn't really work like that. So again, understanding the smaller movements, the smaller progressions, and even being creative, like feeding them outside, or having various stimulus does help, because there's a lot of times where I've seen kids, and I'm using feeding as an example. My sister's a speech therapist, so she's very in tune with all this. But there's times where the kids won't eat inside, but the minute they're outside, they have different stimulus, and their brain just picks it up more, and they're just automatically able to eat. So being creative with that also gives you an idea. Is it something that the child is truly deficient in with that skill, or is it the environment that's going on that is not allowing for the child to learn in that setting, and then being able to pull them out or put them back in whenever they're ready? Protective responses, and I think this is probably one of the biggest things I think for most families is, if someone falls, do they put their hands out? Are there certain responses that they have that protect themselves in case something were to happen when you're not there? And various ways to teach that, again, is a lot of visual training, a lot of vestibular training, and changing the environment and finding ways to modify them, even if you're essentially putting them in a harness and allowing them to fall to a certain angle and seeing if they put their hands out. So these are certain skills that children have to develop anyways through their motor milestones. And how are we doing that, and how is that transferring over to other skills that they're going to need to have? And so this is one of our older, so this person was struck by lightning, had a brain injury when he was 9, and he's 30 now. So this is whether they've had the injury for 3 months or if they've had it for almost 30 years or 20 years. This is kind of an example of some of the things that changing the environment, changing stimulus. This is someone who, hold on, let me see if it works here, who has recurrent falls, and understanding that he tends to fall backwards, so we're teaching him the resistance of walking forward so he has an idea on how to get his balance. Standard traditional things here, it's hard for him to get out of bed, so can he even do a sit-up modified? Again, it seems very basic, but you're surprised on how these fundamental skills carry over into him being able to function upright and standing. Let me see here. And so those are just two. I don't want to do too much of that video, and the idea is, again, making things fun. Kids want to play. They don't want to feel like they're behind white walls. And so finding creative ways to make things playful, very intriguing, and things that really grab their attention is it's key. Whether they have an injury or not, like it's just going to be, you're going to need more of that stimulus if they do. The term gait training really goes into walking. So I know this is a big area for a lot of people is the kids being able to stand and walk. And Shelby will go over a little bit more about traditional ways and what we really need to do to get that set, because it's not always just get them straight into walking. There's some precursors that you need to get there.
So a lot of different ways that gait training or walking is accomplished or taught is through either a harness system where it's taking off some of their body weight support. That way the therapist, there are multiple therapists involved that are able to move the limbs how they need to, let's just say on a on a treadmill. So that's one option, and that's a little bit of a controlled area. And then there's other ways where you can do it through parallel bars. Again, the patient is able to have their hands, their upper extremities apart on something on the parallel bars, and then again you have the therapist almost moving their limbs through or moving their legs through. Now that's just two very simple examples of that, but whether you're doing that or just, even in a standing position, an upright standing position, a pre-gait activity would be just trying to advance the limb forward, or even just trying to do something as simple as weight shifting. So you have to weight shift to one limb to be able to advance the other one, to offload the limb that's trying to go forward. So simple things like that, whether you're just doing weight shifting and learning how far do you have to go where you're not just dumping into that hip, where you're not losing that balance, that's a very big exercise that we do for one of our specific patients that is learning to walk again, because just knowing how far do you go before you are going to fall over, or how far do I need to go in order to get the limb actually off the ground. So that's part of a pre-gait activity, and then of course the advancing of the limb. But even just stepping back from that, from actually just standing or weight shifting, is just getting the actual strength around the hips or the activation of those muscles there. So you can do things where you are doing simple isolated strengthening for either your outside hips, your lateral hip muscles, and also your glutes, your butt muscles. So if you're doing just isolated, targeted exercises there, along with also activation prior to doing any sort of pre-gait or gait activity, is tremendously beneficial. We kind of test that through the same patient that I'm thinking of do we get up and walk right away whenever he walks in, or do we do a few kind of activation or strengthening exercises and see how that correlates and kind of helps his actual gait training. So that's a couple ways that we do it. There's obviously multiple ways to be able to accomplish that, and beneficial ways. Do you want to talk about Matrix?
Yeah, I'll even kind of feed off what you were saying with essentially with walking, right? There's a lot of different components. It's just with walking, you're not walking forward, you're walking sideways, you're turning. So a lot of these skills need to be done, but how are we preparing those skills to happen in a way that the child is safe? So most traditional ways, like she was saying, like, you've seen Riftons. I'm not sure if you're familiar with, it's kind of like the waistband where the child is walking. Those work really well. There's forearm ones. There's a lot of variety of equipment that you can use. But how you're using that equipment also, essentially, like, it tells you how much you're going to progress in certain areas. Because if you're only focused on that one assistive device without including your inner ear with like visual scanning and awareness, it can make that progression off the walker much more challenging. And so, we have this device that we use for kids that are usually like over 14 years old, depending on the height of it. But ultimately what we want to do is anytime that we're thinking about walking, there's a lot of precursors, like what we do at the gym. Like we have, bars that we use with one side. We have poles that they walk with. Like all this is trying to do the same skill with just different stimulus. And because of that, when, let's just say someone's walking with poles versus them walking with the walker, and then you change it one more time where maybe you're just walking with one side, you're going to find what deficit is really like present or prominent, to where they're building skills in different areas depending on how challenging each task is. So the goal is really not to use one form of walking for training. There has to be a variety. And so that variety, even though other ones may seem like they can only take 2 steps, it's so difficult. It actually trains them better to walk better when they have support. So it's like training harder so certain things feel easier. So having that mindset of constantly changing things up really does help with how the brain processes new movement and how it's absorbing new information, apply those skills to certain tasks. And we'll show the videos at the end here because for some reason my computer's too old for me to. Okay. Right now we're kind of flying through some of these, and because I would like to have more one-on-one time with like questions and like problem solving and things like that for everyone else. But really what we look for or what we'd advise to look for in therapists is obviously someone who's passionate, but someone who's experienced and creative. It doesn't even necessarily have to be a PT, and I think that's where a lot of the education is like, well, this person doesn't have the knowledge. You can probably use someone who has an idea of functional movements and just someone who's very creative in a gym setting that'll apply the skills needed to have physical therapy related outcomes. Whether it's someone who's pediatric or neuro focused, or someone who's just okay with thinking outside the box. And I put some credentials here. These are just credentials that they have more formal training, so they have a lot of experience and they're able to use different tools. When we talk about alternative methods, they can use bolsters, they can use stuff that they made from Home Depot. Like, there's a lot of different things that these people with these credentials can do to add variety to some of the things that your child is going through with therapy. CSCS just means a strength and conditioning coach. These people have various experiences with like bungees and cords, and again, using tools to help stimulate the brain. And then as far as home health versus outpatient, there's benefit to both. I mean, I know we have some home health companies and some outpatient companies that work with kiddos, but having that variety of what you can do at home, whether you have a therapist at home or you're doing it yourself, and that's kind of where we're going to dive into in a little bit of the things that you can do on your own that will enhance the progress of what your child is doing on from a PT standpoint, and then essentially communicating with occupational therapists and SLPs, because there's a variety of what they do that needs to be incorporated in PT. It's not just walking. If they're working on swallowing, we might have to focus on certain positions that's going to enhance the skills that they're trying to achieve with what you're doing. So it really is a group effort. So I'll let you go into.
Yeah, so just a little bit about what we do. This is the gym that I was speaking of before. Mm-hmm. So we have if you see the red area, that's the matted area. So like that's kind of like the gymnastics mats. Mm-hmm. That we use that a lot for, either if it is just doing some walking or kind of fall recovery there. That's a really good area where we have that, because that is the most difficult surface probably to stand up from. Mm-hmm. In our gym, in our setting. Then if you look around, it looks almost kind of like a typical gym with the cable machine, the benches, and then the rig where the people are doing pull-ups. And so we use that all a lot. We have our patients doing pull-ups, whether that's assisted or unassisted, using different grips. So whether you're having your hands just like this, or using your hand in different ways, because that really shows also their grip strength, and where we can focus more for helping them with grabbing and holding on to objects. So if you're holding things in different ways, or if you're almost doing pull-ups in different ways, it also tells us, okay, well, how is that correlating to your everyday of what you're picking up and doing? And then, of course, just the plain matted area, that's where we do a lot of our walking. But then even outside of this, we have a big turf area. So on the gait training slide, that had the outdoor uneven surface, and that's a really good one that we use, because you're having to push through the turf, which is essentially push through grass, or even walk through grass. And it's kind of a little safe space, because if they do fall or if they do have to sit down, it's a little bit more cushion than the cement parking lot. But I'm joking. Yeah. But that's the other area that we have. So that's our big, or it's not big, but that's just our gym space that we have here. We're in Oak Hill in Austin. So we use that for our neuro patients, but then we also just have wellness, just training patients that we see, a typical kind of outpatient. And then our specialty is listed here, but then we also deal with a lot of other either autoimmune or neurological diseases as well, and that's where we treat kind of hands-on. So we have a very big understanding and background between, if that's just manual, so hands-on therapy, the vestibular training, the proprioceptive training, the neuro training. We kind of incorporate all areas, or all knowledge in all of those areas, into all of our patients. It's not kind of just targeted, oh, you're just this type of patient, oh, you're just this type of patient. We really use all of our skills for every kind of patient that we see. And then that's what I had said, the wellness training, using the different exercises, and that's here in our gym that we we have on site.
Yeah, and you can see like ropes and rings and a lot of this too, especially for kids that are a lot older, whether, using an example, there was a child who was 9 when they were struck by lightning, and then being able to go back, the kid was playing soccer. And so what's a way for them to still feel like they're in an athletic area? Use a gym. Finding things to help them feel motivated is key, whether it's a gym or anywhere else. And so she explained a little bit more about some of the on-site stuff, but I think the component that we haven't really got into is a lot of the autonomic system. So if y'all attended the presentation this morning, there was a guy who was talking a little bit more about the vagus nerve and all these different things. And when it comes to head injuries, there's a lot that goes on both from an autonomic nervous system, so your fight or flight, your rest and digest, and how you target those two is very specific, because there's certain movements that you can do that target different sections of your spine. So for an example, if there's an area, whether it's a heart or lung breathing issue, there's sections of your neck, there's sections of your upper thoracic spine that you can activate the same muscles that are innervated by that nerve to still get that nerve to function the way it needs to, versus just having to, in conjunction with maybe like some hands-on stimulus and vibration stimulus. So a lot of what we do with our movements that we do for all kids is really incorporating not just the strength and stability in the vestibular part, but really the autonomic side, because a lot of times kids with TBIs also have a lot of GI issues. And so GI issues can limit the amount of core activation that a child has. So you can do sitting all day, but if that's never addressed, it might be a lot more challenging for you to get those progressions that you're looking for. So there is a bit of a science of understanding what areas, whether the person's on site or virtually, being able to target specific nerve roots that'll allow autonomic changes for the better, in addition to complementing the movements, whether it's standing or sitting and those kind of things. And a lot of what we do as well, we do a lot of programming. So it's over the course of 2 months, depending on what the person is currently dealing with. We do personalized videos for that person, or we use our 400 video library where we have a bunch of movements. But whether you're in town or out of town, a lot of what we do is we do a lot of caregiver training. Like our goal is, whether it's from finances or resources or time, being able to set the parents or the caregivers up for success with teaching them there's ways that you can do pretty advanced physical therapy related activities and not be a physical therapist. And so being able to learn those skills and feel like you're still contributing to their recovery, I think is big too, because there's a lot of stress factors that go into that. But there's always options that we can help with teaching you certain things in addition, whether you're receiving therapy or not, that it's still going to benefit your child. And then we also do a lot of more, this kind of goes more into our nerve and posture related manual techniques that we do to help increase the speed of that recovery. And then this is more so, again, for the older children. I'll kind of talk a little bit about this, and I'll do a quick demo, and we'll go into questions. But the idea is a lot of times when kids have these injuries, whether they're using walkers or canes or tripping on themselves, there's a lot of different things. So this device, if they're constantly scuffing their feet and not fully understanding how it is that they're supposed to be walking, it can cause a lot of issues. So with this device, it gives them, again, that awareness, tapping into that vestibular system, that proprioception of what is going on. So I've used this with people with spinal cord lesions, where it's a kind of a combination of a head injury with a spinal cord injury. And that's one thing we also consider as well. A lot of brain injuries aren't just brain injuries. There's always something else accompanying it. So keeping that in mind. So just the easy version of this is, again, this is for between like 14 and like 20 years old. But the idea is that as they step in that tension, the minute they just relax the leg, it pulls it forward. So it gives them that brain to foot connection of how to move the foot versus them trying to scuff their foot or overactivating, especially if they have lower leg tone. So as I keep going here, it's a lot smoother and they're using less energy and again, there's knee straps and other foot straps depending on what needs to be done. But again, this is another alternative method, whether you use this for a child there's straps that you can use on a smaller walker, but there's different ways to get them to do the skill without overexerting themselves and not overdoing it from a fatigue standpoint and also from a tone standpoint. So I think that's really big when you're doing therapy on really anyone with some sort of injury like that. The tone itself could limit a lot of what you do. So learning even how to fatigue the tone. So that's something that we teach a lot at home is what can you do to fatigue that area before you go into the skill, so that way you're better prepared to, or the person's more set up to achieve the goals of the skills or the activities that they're doing. So, perfect. So I was trying to leave more 20 minutes, but we're at 15 minutes. So we're open to any questions, whether it's related to your child, a friend, whatever it might be, but any questions you have on this or about your own, we'll take the next 15 minutes answering questions. Yes?
With talking about, lower tone and fatiguing, and then I think in one of your first slides it showed, like if there's contractures, like how do you kind of continue to work on these things if that's an obstacle? My son, we can't bend his knees and his hips are dislocated, so like what would be some suggestions?
So the type of tone is he more like cross-legged tone? Is it more extensor tone?
He's
More out?
extensor and out.
Okay.
And hyperextended in the knee.
Okay, so does he have ankle motion? Is it just the knee or does he have the ankle?
He has some ankle motion, not at the time.
Okay. Have you, or I guess from, are you currently using a physical therapist? Where is he at from a?
No.
Okay. And then how old is he?
He'll be 3 this month.
3. Okay, so 3. Okay. So there's a lot of other weight-bearing, supportive weight-bearing stuff that you could start off with, especially if there's dislocations, just to build activation in the hips to keep that. So what they call approximation is when the joint stays in the socket, and so there's a group of muscles that are in your hip that once they contract, they keep it in there. So starting off with things like that, I think would be great initially, because if he can't bend his knee, that means he can straight. That means that he can get on his feet in a supportive way. And then being able to gradually build some tone in the hips. And usually, typically, if there's issues in the hips, there's issues in the mid-back, kind of like the connection point. So whether it's getting more mobility there from someone who could do more hands-on, whether it's certain movements, maybe it's certain stretching that you can do. But the way we look at it, like Shelby was mentioning before, you have to look at the whole body, because the issue could be at the ankle, but it actually be coming from improper neck movements. And so how you connect that and how you chop that down versus, I have to focus on the hips. Well, why don't you start on other areas of the body to possibly allow that area to, whether it's to reset or activate more. So as you're doing your slower progressive exercises on the bottom half, you're clearing up the top, so you're better prepared for maybe things that would allow for knee bending. Now, I don't know the degree of contractures. I don't know if it's tone related or if it's full contractures on that, but contractures is a little bit challenging because they sometimes will do tendon releases and all those things. But if it's purely tone related, there's a lot of tone management stuff depending on what they call the modified Ashworth scale. Depending on the number that you have of rigidity of the legs, there's different ways to manage that to fatigue it. Let's say he's standing, he's fatigued, and he's not subluxating. Then you can get in more into either like a modified tall kneeling or a modified quadruped position, depending on what range allows for after he's fatigued. So a lot of that kind of goes into your prep and then reassess him what he's actually doing. Mm-hmm. Yes?
I have a question about how do you fatigue? What are some of the examples that you use of how you can fatigue the tone a little bit? So my son is he's tight here. He has ankle movement. He can move his legs. He walks in a gait trainer support, but he's pretty high tone here. So how could I fatigue some of that tone before we go into working on?
Is this tone where his leg is completely straight or bent?
He can bend it.
Okay. But whenever the tone is engaged, or is it more of like a dynamic tone when he's moving, it just tightens up, or? Okay.
So,
okay.
So if you're moving, his leg is going to hit right there at the knee.
Okay.
You know what I mean? And with his feet, they're going to be down, but he has range of motion in the ankle.
Okay, so he's not limited with motions, only when he moves.
Yes.
Or, to some
Yeah.
degree, yeah.
Yes.
Okay. You want to talk about tall kneeling and quad?
Yeah, so ways that you can do that is prior to to gait training essentially, or even after, or just in conjunction with the gait training, is doing, I'd mentioned the quadruped, so you're getting all 4 limbs on the ground. So you're basically trying to get weight bearing through that leg. So whenever you're saying to fatigue the tone, you're basically trying to work the muscle that is causing the tone. That's maybe a better way to put it. So if you're in tall kneeling, so you're on your knees and
So
your hips
I'll
are
show
fully extended. Yeah, Jonathan
It's
will
like
show.
this.
I'll let
This is
him
tall
demo.
kneeling.
So if you're in this position, you're basically getting an isometric contraction of the muscles that are causing the tone whenever they are concentrically, or whenever they are contracting during the gait training or during the walking. And so if you're essentially fatiguing, so you're working the muscle, it's tired and it's basically not going to be
stretches out,
allowed to contract, to cause that contraction when he's moving, which that's kind of that's basically the goal of it,
Yeah,
like kind of
yeah.
the prep for gait, like some of gait training or pre-gait training.
And yeah, what happens too, once you're in that position too, especially let's say he's fighting that position, like he's trying to kick while he's in that position, that muscle is going to fatigue so much that you're actually going to gain more range of motion. So when he's up, he may not be as fluid, but you'll see that the leg will have less rigidity while he's walking. So that's a creative way to fatigue the muscle, maybe for 5 or so minutes, not to where he's exhausted, where he can't walk. And then for another example, we have someone who has arm flexor tone. So that's a huge one in most. And so if they have full range of motion passively, meaning you taking them through there, then that's a plus. So then you can get them into, well, it's all fours, even just putting the hand down if they're sitting down, and working that so much, whether you're shifting, whether they're trying to sustain the position, especially if it's only wrist, getting them into that wrist extension. Like we have a guy that we work with that the first 5 minutes is to completely fatigue the arm. Because what happens is that when he walks, as soon as he walks, his arm comes up. So the minute that we start fatiguing the arm, it's only wrist on the bottom, but his arm is straighter. So that doesn't cause his body to overactivate while he's walking, but it's allowing him to walk in a way that he's, I don't want to say supposed to feel, but it's more normal for him, and then he can apply that skill at some point once he understands where to keep the arm. Because a lot of times it's not so much that the arm automatically comes up, it's the stress response of walking, of not understanding, that causes that response. So that could be different in just about anyone.
And I can see that because when he's walking, he's using his whole body.
Exactly, especially if
it's a
they're
stress
pressing down on
response, yeah.
something.
He's like,
Yeah.
Yeah, a lot of that energy can go into the leg.
he's gonna go back this
Yep.
way and then legs are back.
And then legs just go.
His legs are going with it.
What's your question?
Earlier, you were talking about length, and you were mentioning that you have a patient that you put a flip-flop underneath.
Oh, yeah.
Uh-huh.
What do you do when the length is so minor
Uh-huh.
that you can't put anything underneath it, but it's affecting?
Lift.
Can you do either a heel lift or a slight shoe lift? Like, because you can get them in different
Like
widths.
inserts.
Yeah, different inserts. So the one that we have for him, he has a 1 inch, let's just say. So we got him like the 1 inch little flip-flop attachment to the bottom of his shoe. But if yours is so okay,
so
Or
Go
you can
ahead.
even put it inside
Yeah.
the shoe too, yeah.
Doctor,
Yeah.
and they're telling me that he doesn't have a length discrepancy, but he does. The therapist and I see it.
Okay.
I would do a
like,
lift.
When
They're just
he's
an insert.
moving, we can see it, but then when we
Lay him down.
lay him down to measure, there's no length probably there.
Oh, okay. So then
Oh, I
that's probably more
maybe it's not
movement based then. So if when he's at rest and it's there, the minute it shifts, it might be a postural thing that the hip is hiking up and it's changing the way the leg appears to be on the ground.
He dislocated that hip.
That's
So yeah. So if it's set when you're laying down,
Okay.
it's technically not, but you can get a I guess you'd say a like length in standing just by mechanically what's going on at the hip and the knee.
I would try to get an insert for the shoe, either if that's a or just like one
Even
foot, like you
dynamically.
can do you could do a like a, what are they, like an orthotic kind of insert,
Like
just
a
like
Dr.
something that
Scholl's
you
little
buy,
thing, just like a heel lift.
And just use it for that
sometimes
one.
you can use that during his walking,
yeah.
and then just, excuse me?
They can even add it just right to your AFO and just.
Yeah.
Yeah,
Yeah, if
that
you have a
too.
brace, they can add it on the
Uh-huh.
bottom.
Yeah.
Yes, AFOs either.
Okay.
He is against all
Mm,
devices
assisted devices.
Then it might be worth even finding other.
There's no one else.
Okay.
We live in such a rural area.
Okay.
That we are very, very limited. We're almost done with PT though.
Okay.
Like technically.
No, I
we're
got you,
not actually done with PT, but technically we're almost done with it. At the end of that, I'm gonna force the AFOs.
Yeah. So.
Ever since my son's accident, he's in tow.
Oh, okay.
And also out tow at the same time. Like one of his fits is out tow, and one is in tow, and then when he walks, they both go in tow, and he's also a close step.
Gotcha.
So and then also since the accident, he now has a limp, so he is just really struggling.
Yeah, you can use just like a heel lift or like a heel cushion, like from Walmart, that you can just shove in the other shoe, and just temporarily during training, just to see if that helps normal it out, and then phase it out to see if it gets better.
Okay.
Go ahead.
What are your thoughts on using like NMES, like electrical stimulation for
Yeah.
the muscle?
I guess it just depends on what you're looking for. I like the NMES a lot for people who have foot drop, just as a way to try to get that foot up. I've seen it for like hips. I think really using whatever modalities that you feel like is beneficial. I've seen like maybe like I haven't had as much success with NMES given the severity of brain injuries that I've seen or that we've seen. But yeah, I think when you can utilize it, I would definitely use that as a way to get information to that muscle.
Did you have a question? No.
No.
That's okay.
Perfect time. Oh, go
I have
ahead.
another question,
Yeah.
but I wanted to make sure others
Yeah,
understood.
yeah.
So you were saying, find a new one. What is your opinion on assisted devices?
I think
Yeah.
like whatever
can get them
you have
to
to
the
think
functional.
functional, and like if now for an example, if someone cannot do certain things, let's just say with a walker, okay, if functionally they're able to get up and walk and move around, and let's say a Rifton, you have to think about upright weight bearing also improves gut, being able to move bowels, and so there's a lot of not just from standing, so whatever's keeping the body going, then I would say yes. But when you get in positions where, let's say a child is using an assistive device and they have big potential to be without it, then you don't want to hold on to it for too long. You have to what we call
Lean off of it.
not so much like wearing schedules, but like you use it for a certain period of time and then you do it without. But you would like to transition off. So each one have their own. Just it really is dependent on the person.
Yeah.
But no, I do believe in them. But I think that if the person is starting to get skills past it, you have to learn how to wean off. Yeah. And as long as it's not limiting them from progressing too. But sometimes assistive devices, let's say AFO, sometimes if they're getting activation in the foot and they keep making them wear an AFO, it's going to limit their ability to get more strength in the foot, knowing that they're already getting it, but they're still wearing the AFO.
Right.
So there's like certain things like that.
I feel like he's at the point right now where he's not going to progress.
Past it, okay.
Because he's hitting it, yeah.
And so I think that a lot of that is
We're
communication
being
with,
all, pretty much everything.
yeah. I mean, I know it's easier said, but like
Yeah.
communication between PTs and doctors, and honestly, the way I look at it, like as an advocate for all this, like if your medical provider, regardless of what field that they're in, is not giving you what you need, it's always okay just to look, because you have to do what's best for your child, not best for the ego. So, and just being completely transparent. So, any more questions?
What is like other things to like fatigue the arm? Like
What can you give me an example of? Because I think if you give me an example, I can tell you a little bit more of.
when he tries to do something, like he can move it freely, like when he's not thinking about it. But then like if he's trying to do something, it's like he
Is it more this or this?
this.
Okay, so a lot of times too, you can do like passive movement. So for an example, if there's certain ways to fatigue and you can't get it, a lot of times like that resisted back and forth,
Bringing it.
just slowly fatiguing, because it'll catch, it'll release, catch, release, until finally it just releases the whole way through. So there's certain ways like that, but that's typically what we do as physical therapists, is doing quick passive movements, because spasticity is velocity dependent. So how fast you move the joint, a lot of times that's when they're trying to move and they just get stuck. It's based on that. So when you break that up more, then it allows them to fatigue it, and then so they're less likely maybe from here, they're like here. Because it does take a bit. It's not going to just go completely straight, but it's a slower progressive.
When he's doing something, you can go in and kind of try to move it.
You can do like a
up
little
and
bit
down,
beforehand
out.
and then check it again to see if it's less bending.
Okay.
Does that make sense?
Yes.
Okay. And we'll do one more question. You good?
So in gait, if one leg is here and the other leg is sweeping, do you feel like that's an issue with spine? Like what things?
Both.
You have to look at both.
Any sort of sweeping, especially kind of like bringing out and in, is
Can be
like
from-
front hip muscle issues, back hip muscle instabilities, and then even what you're doing here at the trunk. Because a lot of times what happens at the trunk causes whatever's going on here. So again, diving into what we said before, like, is there any GI issues? Like even diving deeper into things that you don't think is going to be a problem, you would like to assess, because those things can still change your biomechanics. Yeah.
So do you guys typically do that? I mean, I'm not in Austin, but we don't really mind traveling anywhere. So do you actually do like a full assessment?
Yeah, we do it virtually.
Things that we could work on?
And then send personalized videos and literally positioning with you while you're, say, if you're at a state, we're literally on the call and going step by step through exactly to see, can you do it, can you not do it, is there another alternative? So yeah, everything we do is we're teaching everything that we can based on the setting that you're in. But yeah, but we do it virtually. We see a lot of virtuals actually. So, but yeah, and if you have more information, our booth is kind of like tucked in that little cafeteria area. But thank you so much for coming, and enjoy the rest of the things.
Thanks, guys.
Yeah.
Right on.